Okay, well, thank you. I'm welcome everybody to the latest meeting of the Health and Wellbeing Board in Hammersmith and Fulham, the place where the Council and the Health Service and other stakeholders all come together on the basis of equality to talk about how we can make health and wellbeing better in the borough. And I just will run through, before we go into the meeting proper, just run through a little bit of housekeeping, if that's okay. I don't know if I just said at the beginning, but my name is Ben Coleman, and I'm the Cabinet Member for Health and Adult Social Care here for Hammersmith and Fulham Council. And this meeting is being live streamed on YouTube, so you can watch it again. Anything exciting that you missed, you can always watch again there. It's going to be a break a part of the way through the meeting, about after an hour of the meeting. That's because one of our people participating today has a talent typist, and many years ago I used to be the Director of Communications for what was then called the RNID, and I remember the fantastic practice of meetings stopping after, yeah, really, Jane. And I remember the fantastic practice of the meetings stopping after an hour to give the talent typist and the signers a break, and I always thought it was a tremendous discipline. So I'm very happy that we can introduce that here today. And Bathsheba, if I find myself forgetting to observe that discipline, come in, tell me, because it's important we give the talent typist a proper break. When we have the break, I just ask you all not to leave the Zoom call. It's just the way the technology works. Turn your camera off, fine, mute your microphone until we're ready to reconvene, but please don't actually leave the call itself. Great. Otherwise, you're all doing it. If you could switch off your mobile phones, you're all muted. It's helpful if you keep yourselves on mute during the meeting to cut out background noise. If you'd like to raise something, please use the raise a hand function or wave your hand, or if you can't get attention any other way, just come in and say that you'd like to say something, because the important thing is that you're heard. And please feel free to use the chat function if you'd like, although I won't necessarily be dipping into it as much as might be ideal, to be quite honest. So, and when you speak, it'd be great if you could come on, and I can appreciate you keeping your, it's nice to have your screens on if we can have your screens, we can have your face in the meeting. It's nice, it's friendlier, and it's just we feel we're more together as a group of mates. If you don't want to, though, to preserve bandwidth, I understand that, but please do come in and let us put the camera on if you want to say something. That would be helpful. James, hello. Thank you for doing that. So do we have any, so let's go into the meeting proper by just starting off with apologies for absence. And I'll run through the, Bathsheba, you're on mute.
Chair, we have apologies for absence from Glendine Shepherd, Mark Kent, who is unfortunately unable to join through because of his tech limitations. He's going to try via smartphone. And we have apologies also from Janet Cree, Councillor Richardson, and Councillor Colhane.
What I'm going to do is I'm just going to very quickly, right, Councillor Colhane has gone to the Teams one. So if you could just send him quickly, Bathsheba, a note just to say where we are here, that would be great. Thanks, I'll just have a note from you. What I'm just going to do is just ask you each very quickly to introduce yourselves, if you wouldn't mind, and I'm going to go through the names that I see them just on the right of my screen. So you've got me, I've introduced myself as the Cabinet Member for Health and Adult Social Care. I keep saying Bathsheba to Bathsheba Moore, who's the governance and the clerk person here with us. Patricia, can I say a quick word?
Hi everyone, I'm Patricia Pudley. I'm a Cabinet Assistant for Health and Social Care. Sorry, I had to think about that. Sorry, Chief Ed.
That's good, you know, that's cool. James.
Hello everybody, I'm a GP in Hammersmith and Fulham. I'm James Kavanagh, and I'm the chair of Hammersmith and Fulham CCG.
Which is the Clinical Commissioning Group. Which,
sorry, it's the Clinical Commissioning Group for Hammersmith and Fulham, quite correct.
It's all the health services here. Brilliant, thank you. Cheryl. Cheryl Anglin-Thompson, I've got you here, but if you're able just to say who you are.
Hello, I hope, can you hear me?
Yes, that's great.
Cheryl Anglin-Thompson, Principal Accountant and Health Partnership Manager.
Right,
with the Council, Hammersmith and Fulham.
It's always good to say the organisation, because not everybody would know it. Thank you, that's great. Linda Jackson.
Hi everybody, my name is Linda Jackson. I'm the COVID-19 COVID-19 director for Hammersmith and Fulham Council. We're all struggling tonight.
You're all struggling. Okay, let's hope we make it through. We're sorry we're not all together. We can't have the usual bottles of wine. No, that's a small joke. Very small. Deborah Parkin.
Hi, I'm Deborah Parkin. I'm the Assistant Director of Primary Care at Hammersmith and Fulham CCG.
Brilliant, thank you. And Jackie McShannon. Jackie, you may be hearing us, and if not, I'll come back to you. Now, who is Jane's iPad? Jane, it's you. Would you like to introduce yourself?
I'm Jane Wilbur, a local resident and a member of Hammersmith and Fulham Health Watch Committee.
Thank you, welcome. And we've got Maisie, is that right, from Health Watch as well? I'm not sure we've got this one. It says Health Watch, Hammersmith and Fulham.
That's correct, Chair. Good evening, Maisie McKenzie, Operational Manager, Health Watch, Hammersmith and Fulham. Good evening.
Great, thank you, welcome. And Jackie?
Thank you.
Yeah, apologies. I've got a little bit of technical difficulties, so I might drop on and off, but I'm Jackie McShannon. I'm Director of Children's Services, Hammersmith and Fulham. Pleased to be here.
Great, thank you. Kim Smith?
Evening, everybody. I'm Kim Smith. I'm the Chief Executive of Hammersmith and Fulham Council. Thank you for the invite. Apologies in advance because I'll drop in and out, but really pleased to be here at, I think it's only my second Health and Wellbeing Board.
An honour for us. As I said to if any of you need to drop in and out, please do so. But if you're planning to come back in, please stay in the meeting, but just put your microphone and your camera off, and that's absolutely fine. Thank you. Larry Culhane?
Hi everybody, apologies, I was a tad late. I'm Larry Cohen. I'm the Cabinet Member for Children and Education in Hammersmith and Fulham.
Very nice to see you, thank you. LR46, who's that? Who's hiding behind LR46? Oh, it's Lisa Redfern.
It's me, LR46, yeah. Lisa Redfern, hi, Strategic Director for Social Care, Hammersmith and Fulham Council.
Great, thank you. And I'm guessing that, yeah, and Nikki Lang.
Hi, I'm Nikki Lang. I'm the Director of Public Health for Hammersmith and Fulham. Sorry, the video didn't work right away.
Philip Johnson.
Hi, yeah, Philippa Johnson. I'm the Director of Ops for Central London Community Healthcare, so the Community Trust, but also a role as the ICP Director for Health and co-chair the ICP with Lisa.
Right, so the ICP is the Integrated Care Partnership.
Yes, sorry.
We'll be talking about that a bit later in this meeting. That's great. Thank you for coming. Thank you. Sue Rooston.
Hi everyone, I'm Sue Rooston. I'm the Lead Borough Director for Hammersmith and Fulham CCG.
Brilliant. And Toby Hyde?
Hi, I'm Deputy Director of Transformation at Imperial that look after Charing Cross and the Hammersmith hospitals in the borough and are representative on this board.
Thank you. And am I right in thinking that we've got Bob Plager coming to the meeting with Ashford? Is that right at some point?
Yes.
Yeah, good. Okay, from Imperial as well. So great. Well, that's it. I hope I haven't got as I was reading out names, Teams very kindly rearrange them all the time for me. So I haven't missed anyone out. Have I missed anyone out? Brilliant. Good. That's good to hear that I haven't. Or silence. So I'll just run through the agenda, but before I do that, I just think we should mark. I know we begin our meetings, but our last one was quite a long while ago, long before Christmas. And as you know, yesterday marked a year since the country, marked a year since deaths that we started counting deaths from COVID, and we remembered 146,000 people who this country has lost from COVID, and that's right across the UK. And the day before that, we in Hammersmith and Fulham actually marked our anniversary of the first person in our borough to lose their life to COVID. On the 22nd of March 2020. And in the 12 months that have followed, I'm sorry to report that COVID has actually taken the lives of 589 residents of this borough. And in so many instances, they were friends of ours, and they were families, and they were neighbours. And across the country, it's estimated that not only the people have died, but the people who've been affected by bereavement number as many as 6 million people. So we have the tragedy of the 146,000 people across the country, the 589 in our borough who've lost their lives, and the many millions of people across the country, 6 million, and the thousands in our borough who've been affected by this tragedy. And I know that everyone in the borough sends our heartfelt condolences to everyone, whether it's a family member or a friend who's mourning the loss of a loved one. I also think it's probably important to say that we are, as a country, and certainly the borough, becoming increasingly aware of the debilitating effects of having had the virus and how that can go on for, in some people's cases now, it's almost a year. While many people recover fine from the virus, there's some for whom the after effects are very, very serious and they drag on for a very long time. It's called long COVID. And I think we recognise, again, the suffering that these people are going through and that more needs to be done for them. And that's something I hope we can address in future meetings. So I just wanted at the beginning, I'm not going to ask for silence because we had a silence at the beginning of the last meeting, but I just wanted us to recognise that it's a year since this all began. And a lot of people have lost their lives, a lot of people suffering, and you've all worked incredibly hard to help everyone in the borough. I'm grateful for that, thank you. So our agenda today is, we're going to start with something which is very important, but shouldn't perhaps take too long, which is to sign off the Better Care Fund agreement, which the borough has with the NHS, and I'll ask Lisa to talk about that in a minute. We're then going to talk how, and if I could ask everyone just to stay on mute for the moment, would that be all right? Unless they're speaking, that would be great. We're then going to talk about how vaccination is going in the borough and how we're addressing the challenges, which will include talking about health inequalities. And then we'll have a break, as I mentioned, for 5 to 10 minutes. And then we're going to move into perhaps a bigger discussion, a more serious discussion of health inequalities, which I think is an issue which we really need to grapple with in a very serious way now. And our final item is going to be, as we touched on a minute ago, we're going to be looking at how we're making the new partnership arrangements work. This is the arrangements between the health service and the council through something called the Integrated Care Partnership. And I have to say, one of the positive things to have come out of this awful time is the fact that we as a council and we as an NHS are working better than we ever have done before and understand each other better. And this is something that we must keep going and build on, so we really improve the outcomes for residents. So we can talk a bit about that when we talk about the Integrated Care Partnership. So, leaving this meeting, you had the minutes of the last meeting, which was a while ago, as I say, on the 2nd of December. Just wonder whether any matters arising out of that, anything anyone would like to wish to raise? And quickly just go through what was why not go through it, but we looked at dementia. We talked about the health integration in the North West London area. We talked about GP access to digital services. All these are areas, and we talked about the food action plan. These are all areas that we're going to be coming back to in future meetings. But is there anything that you'd like to raise now? If not, I would take the minutes as being approved, and I agree the minutes, actually. So that brings us to the first formal item, which is the Better Care Fund. I'm going to ask Lisa to introduce. I just want to say the Better Care Fund, as it says in your papers, it provides financial support to council and NHS organisations to plan and deliver local services jointly. And we have an agreement every year. We've got one coming up until 2021, and so we're being asked formally to approve this. Lisa, would you like to take us through it?
Yes, thanks, Chair. As Ben said, this should be a very brief item, hopefully. A lot of work's gone on behind the scenes over the past 6 to 8 months, really, to get this work in order. Essentially, the board's asked to review, comment and endorse the Better Care Fund. And the Better Care Fund is there, it's a vehicle, it's there to support and help joint working. We've developed a joint set of priorities, which we closely monitor and review between ourselves and the CCG. So all key stakeholders have been involved, and yeah, that's all I want to say, Chair. I think it's for the board it has to formally come to the Health and Wellbeing Board for members to sign off and agree.
Okay, thank you. Just to note, we're talking about a proposed budget of £49 million. Just correct me if I'm wrong from the papers, of which the CCG contributions 31 and the local authority contributions just under 18 million. And otherwise, those are headlines, but there's lots more about how we're going to try and do things together, get people out of hospital more quickly, and a range of issues. Is there anything anybody would like to ask about the paper? I know quite a lot of you have been quite closely involved in its preparation, so you may have answered all the questions you want at this stage. Anyone like to ask any questions about that? Raise any issues? Okay, in that case, yeah, in that case, I'm going to, on your behalf, I'm going to agree on behalf of the Health Member the planned expenditure and agree the proposed themes for 2021, and look forward to receiving an end of year report outlining the outcomes of each of the schemes and the difference they've made for residents. And I think that's a really hopeful thing, that everything we do, we understand the outcomes and the difference they've made. So if you're happy with that, that's agreed. Thank you.
Thank you.
That's great. Thank you very much for your work and the work of everyone who's been involved in that. It's a major piece of work. And I believe, I can't remember this year, Lisa, did you get lots of notice from the NHS about how to fill it out?
No, never do. We never do. Any of us, no. So we just have to crack on and assume, all of us, including House colleagues, that it's going to be there until told otherwise.
It's extraordinary, isn't it? Every year we get a Better Care Fund. We know we're going to have it, and every year we have to wait to the last minute for the NHS to send out the guidelines. Yeah, not great, is it? But anyway, and it's a great document to put together. So we're going to do good work. Thank you very much. So the next item, and thank you, Cheryl, for that. And by the way, can I just welcome Vanessa Andro, who's come to the meeting. She's the deputy chair of or vice chair of the Wellbeing board, and senior in the CCG. So it's good to have you here, Vanessa.
Hi, sorry, Ben. I had some system failures. It kept wanting me to join an NHS Teams meeting, and I think we've previously done this through Teams. And so I sat in a lobby for quite a while with Sue going, "Where are you?" and me going, "I'm in the lobby. Why won't someone let me in?" And then it turned out, and I've got a slight issue because I'm still at work and I need to get home because the surgery is going to shut before this meeting ends.
Right. So
at some point, judiciously, I'm going to have to hop on my bicycle and cycle home and log back into the meeting.
Okay, but Vanessa, you're going to have to find some way of logging back in, but Ashika will have to help you do that, because I've been told that people aren't meant to log off.
I might be able to log in on my phone in a seamless transition so that I just transfer it over.
I'll leave it to you, Ambassador, to sort out. It's good to have you here. And yeah, great. Okay, well, we'll talk about vaccination now. That's the next item. The vaccination, as you may or may not be aware, everyone here is aware, is a responsibility of the National Health Service. We talked about flu vaccination at our last meeting, and to be quite honest, it was a bit of a rough discussion in bits, because we felt that flu vaccination should have taken. There's been more of a pushover over the last 5 years, but we discussed that, and we can come back to flu another time. But today, it'd be good to hear what the CCG and the council, with council support, are doing, what the activity is, what their plans for COVID and also flu coming to the future vaccination in the borough are, and talk perhaps about what support that we can all provide as part of that. So who'd like to start that? I've got Sue and Linda down to talk on that. Who'd like to kick off?
So I think Sue's going to start, Councillor.
Yeah.
Okay. Thanks.
Thank you. So I'll start, and then obviously Linda, if I miss anything, I'm sure you can fill in the gaps for me. So in your papers, you will see that there's a version of a plan that we submitted last week. This is a joint plan between the CCG and the local authority. It has been reviewed, as I understand, at a sort of a high level at Northwest London and indeed London, and it was well received by both, as all the boroughs have submitted their local plans by borough, and obviously we are continuing to sort of look at the improvement around uptake. So just to give you some idea of the current levels of uptake, 97% of our care home residents have been vaccinated in Hammersmith and Fulham. We're currently at 82.1% for our 80 plus cohort, 86% for our 75 to 79s, 76% for our clinically extremely vulnerable, 84% for our 70 to 74-year-olds, and 82.9% for our 65 to 69. That takes us up to yesterday's figures. I think we did meet yesterday and they've improved from yesterday. So actually, it just goes to show that obviously the ongoing work that we are doing around the vaccines. In addition, we've now got a mass vaccination site that opened last Monday in Hammersmith. That's at the Novotel in the centre of Hammersmith. And yesterday I reported that they did over 5,000 vaccines. Today it's 6,370. So they've increased again, obviously from the activity yesterday. We've got quite a lot of work to do to increase our uptake in the hard to reach groups and the groups that are hesitant about receiving the vaccine. And that work is ongoing between the CCG, the local authority and our colleagues. And I understand Bob is going to be joining because there's a much broader North West London piece of work around vaccine hesitancy, but also very much a local piece of work for us and the local authority to deliver. We've referenced in the documentation that we are anticipating the use of pharmacy sites. We have one pharmacy which isn't ideally geographically located within the borough, but we also have put forward options for additional pharmacy sites. At the moment, there are no current plans to formally provide those in Hammersmith and Fulham. However, that will be reviewed towards the end of April, beginning of May, but we are looking to mitigate that by having some discussions around pop-up clinics and how we best use the geography within Hammersmith and Fulham. I think the plan sort of sets out our model. We are anticipating between now and the middle of April quite a significant number of second doses that we will be focusing on. Obviously the patients that received their first dose just before Christmas and early into the new year will now be due their second dose, and that will be our main focus. It's also poignant to say that given that there has been a lot of national press around vaccine supply, it is likely that we will still get vaccine supply in the borough between now and the end of April. We've got our delivery dates scheduled up until mid-April, but we are waiting to hear what deliveries we will get following that, and then we plan accordingly, either on first doses or second doses. I don't know, Linda, if you want to add anything. I think I'll stop there and see if I've missed anything.
Yeah, so I think it's really important to say that this has been a journey for us, and we've certainly taken the learning on board as part of the journey. So right at the start, we weren't able to identify why people necessarily didn't want to take the vaccine. Was it a fact that it just wasn't the right time for them, or were there some hesitancy? So we've done lots of work on that, and Bob Claber will talk about that when he comes. But actually in Hammersmith and Fulham, we've taken that on board, and we're now jointly working with the GP Federation, where our CAN contact centre that we set up last March to help people in the community and the residents are now actually doing follow-up phone calls with people. So for those people who have not taken up the offer of a vaccination, and that's fine, but we're just ringing people to say, is there something we can do? Is there something we can help you with? Is it a case of transport? Do you need more information? And that's working really well. We've also identified people who are in receipt of home care who may not have been offered a home visit. So we've been doing calls to those people as well, and that's good. We've not found lots of people who haven't been offered a home visit, which is great, but we have actually found 3 people this week. So it's 3 people matter. So we've taken a lot of the learning from this and building this, because this is a model that will work for us in the future when we've got other vaccinations such as flu, MMR, So we're going to take all that learning from that as well. So as part of the plan, there is what we call a vaccine equity plan. Forgive the language. We are very structured in our NHS plan. We wanted it all bells and whistles, but we had to stick to the format. So, but we're also looking at how we can use this into the long-term planning of how we can work together, how we can deploy pop-up clinics, as Sue said. And we're doing a lot of work with our faith forum and our communities to get our community leaders to give messages out there. And I know we'll come on to that shortly, but that's been a really successful piece of work as well. So it's an iterative plan, it's a live plan, it's not one that sits on the shelf. As the vaccine gets deployed further, we will test it further, we will carry on to do more, but we've certainly had really good success so far at the mass vaccination site. So thank you to all our partners who are working really hard on that. I'm going to stop there, Chair, if that's okay.
Yeah, that's great. Thank you. Take some questions, some initial questions. So would anyone like to just pick up anything that's been said or anything that's on their minds about vaccine? I guess I think it's a duty bound. We're getting we touched on this, but we meet obviously and talk about these things regularly. But just as Health and Wellbeing Board, we're getting the borough is and the NHS is getting criticism, perhaps unfairly, for having lower vaccination rates than neighbouring boroughs. Although there are big problems in Kensington and Westminster, I know as well. And I just wondered if you'd like to say anything in response to that. Somebody might say, "Well, this isn't good." Explain the situation. And why we might be seeing more in other boroughs. James, did you want to comment on that first? Yeah, sure.
Yeah, so when I'm not being CCG person, I'm a GP, and I spend a lot of time talking to patients about health matters and health beliefs. And we work with a huge variety of communities in Hammersmith. And one of the reasons I love working here is because we have such a diverse population. And I think what I've learned over the last few months is the language you use and the time you invest in talking to people about their perception really does pay dividends. And we and my colleagues across the borough have learned more about people's health beliefs in this 3 months, and I think I've done in my career, because we've had to proactively reach out to these groups and sit down and try and understand why they don't see things as an imminent risk, and it is that conversation about risk which is so important. But what I say is, what I found is that when you do put that time in and you do sit and listen and hear what they believe, you can make headway with the group. And I think what I would take from that as well is that flu vaccinations, cervical smears, all kinds of screening that the NHS asks the public to engage with would benefit from exactly the same type of engagement. So it is a challenge, but it's a great learning period for all the people who work with these communities in Hammersmith and Fulham, and in some ways invaluable because of that.
Right. Okay. Thank you, James. So by the way, can you hear me? Or am I very quiet? Just someone just said I was quite quiet. So
I can hear you.
Okay,
we can hear you.
You're quieter than James, Ben, but I don't know if that's a reference point or not.
It is going quiet sometimes.
Okay.
Not heard anyone say that about Ben before.
No, James, or indeed either of us, I think, really. But we will. You just let me know if you can't hear me. I'll try not to shout. So no, that's helpful, James. So we'll come more onto that. I just wondered though, we are getting criticism, and it's been in, it's out of date now, but it was in the newspapers that we're vaccinating fewer people in this borough than in neighbouring boroughs. And I just want specifically to understand if that's right, and if so, why that might be the case. I didn't see what.
Yeah, so I'll come in on that. So I think we there were a number of targets that we were required to achieve by certain times and certain sort of points, and obviously those targets were quite high in terms of the delivery, particularly around the over 80s vaccinations. However, as part of my presentation, I did read out where we are at currently, and I think, you know, notwithstanding, you know, there is more work to do. We are over 82% on our over 80s now, and cohorts 1 to 4, we're doing much better. So I think, you know, maybe we had a bit more of a slow start and we needed to sort of, you know, pick up the pace, but we certainly have done that, and it is not through the want of, you know, trying in terms of delivery. The PCN sites that have been operational have been open sort of, you know, 12 hours a day plus when they have their deliveries, and they have been calling people and getting as many people through the door as possible. But the reality is also that there are some people that are hesitant about it. Some people want to delay, wait for others to have it and see, you know, what happens to them. And obviously all of those things factor into sort of people's personal lives.
Yeah, no, absolutely. Are we very different from other boroughs? Have we got more of that, or is it pretty much the same as another? The question I was asking is because we're getting this comment is obviously there are issues which are common to everyone, but why have we got fewer people on paper? Why does it look as if we've had fewer people vaccinated?
And that's the work that Linda alluded to in terms of us understanding our broader population and the reasons why that people, and it's many and varied. You know, you can talk to, and I'm sure Vanessa and James will have incidents where as clinicians they've been talking to patients and their reasons and rationale for not accepting or not wanting to have the vaccine will be very different depending on who you talk to. I think, you know, I want to say that I'm really proud of our PCNs and the work that they've done for practices to, you know, set up 3 vaccination centres and deliver the level of vaccine that we have. So you can argue that we're lower down in the league tables than perhaps some others, but I think, you know, we are definitely getting there. And, you know, the figures I gave to you yesterday, Ben, were lower. We're doing it every day. You know, there is an increase and people are changing their minds and people are coming in and having that vaccine. So I think we can all play our part in increasing that uptake.
Good. Well, that's very helpful, which brings me to something that Linda touched on, which would be good to hear a little bit about what we're trying to do. And we have some examples here of trying to increase the uptake. And one thing that, and James, you talked about having conversations with patients, which is very helpful. But I see I've fallen into the habit of calling them patients, which I was always trying to fight against. I don't think somebody's a patient unless they're coming to you because they're ill. But anyway, that's just me. But we're also trying to do outreach, and I wonder if I could ask Bathsheba to talk a little bit about what we're doing to try and reach out to the community, so we can have conversations with the community, by the community, to try and address whether we call it hesitancy or whatever.
Ben, can you see there's a couple of hands up? I don't know if you can see that.
No, I can't actually. Sorry, that's the trouble.
No, it's all right. It's Patricia and Toby.
Oh no, I can't see them. I sort of didn't see them. I'm sorry. I apologise for that. Was Toby? Toby, did you have it? Did you have to put your proper hand up, as it were, your virtual hand, and Patricia as well?
It was definitely Patricia first.
I can't see. Bathsheba, I can't see anyone's virtual hands. Bathsheba, can you?
Yes, I can actually. Do you want me to prompt you if I see them again?
Yes, do prompt me. I'm going to take, before I bring you in, Bathsheba, then, before I bring you in, if you wouldn't mind.
Yep.
These people got hands up. I'll take Patricia and then Toby. Yeah.
Okay, thanks, Ben. Yeah. So the question I think is to Sue, really. Did I hear right that you said 76% have been taken up by the clinically extremely vulnerable group? Up to yesterday.
No, it was for the clinically extremely. It's 76%.
Yeah. So how many people is that? Because I have a difficulty in percentage. It could be 76% of anything. So.
That's a question. I don't have the detail of the numbers, but I can certainly get that for you. We have got that. I've got the numbers on the 80 plus, the 75s and the 70s, but I haven't got the CEDs, but I can get that for you, Patricia.
That'd be great, Sue. Thank you. And the second part is there a reason why the clinically extremely vulnerable groups hasn't taken this up? Because, all right, 76 seems a high number, but actually this has been going on since early February, so I'm just a bit surprised that people that have been shielding for nearly a year wouldn't want to get their jab and kind of get back to their life.
Yeah.
Just kind of a bit surprised. advice.
I think the other areas, so some of those patients will also be included in the other cohorts as well. And there is a difference in some of the coding. So some of the clinically, and James and Vanessa will probably want to come in on this. So we've got a coding for clinically extremely vulnerable, but there will also be some of our clinically extremely vulnerable that sit in the other cohorts because of their age, and they've been picked up through that route.
So is there any way we can kind of cross-match that to bring down, because I'm just slightly concerned that I understand what you're saying, but if it's because of that and it makes sense, then I think maybe some kind of cost reference.
So Patricia, if I can just assure you, every person who's on that list has been offered the vaccine.
Yeah.
I think then we start getting into the nuance of what are the reasons they have not received the vaccine.
Yeah.
In some people's cases, it is a flat out refusal. And we keep going back to them, and we will continue to go back to them because we want to understand why they want to refuse. In other people's cases, it's relatives who are refusing, and they have power of attorney over their health beliefs. And there are cases that go into the courts of protection about such cases. That does take time. And there are examples in other parts of London, other parts of the country, where the courts of protection have ruled on those cases. And what we're not doing is simply taking no for an answer, but they have all been offered the vaccine.
That's great. Thank you, James.
So also, I'd just like to come in
Vanessa,
at a point.
would you be all right coming on camera?
Can I say something, Ben?
Yeah, no, I'm going to bring you in. I'm just going to request, because at the beginning of the meeting, which I realised you couldn't get into, we were wondering if people, when they speak, could put themselves on camera. Would that be okay for you?
Yes, if I can work out how to do that. There we go.
Thank you.
There I am.
Here you are.
In my happy little clinical room.
Nice.
I felt that everyone didn't need to look at my sharp spin while I was busy in this meeting. So at least you know I'm not lying about where I am. I'm very identifiable. I was just going to say that I think the really important thing is, so I would echo what James said, that every single patient has been contacted unless they are abroad, and we have got some that are abroad. What I would note is the extremely large differential between the flu vaccine uptake and the COVID vaccine uptake, and especially in this group of people, which is largely the same people who get offered the flu vaccine. So I can tell you that the people who are not having the flu vaccine are not having the flu vaccine because they don't want the flu vaccine. If we have got such huge numbers for COVID compared to where we've been with the flu vaccination, and every year we tell you with flu vaccination that we're approaching everybody and doing everything we can, and then when we have a new vaccine that people are more motivated to get, you can see the differential. And I have heard people come into the COVID clinic because we have to ask and screen them and say, we're just checking that you haven't had a flu vaccination in the last 7 days. And they will say, oh no, haven't had a flu vaccination in my life and not intending to either. So there is a real disparity. And I think it does give you cause for celebration that the numbers are so much higher with the COVID vaccination. I realise that we can still do better, so I'm not saying rest on our laurels, but we have done an amazing job, particularly when you consider the vaccine hesitancy that we faced before. And we do tend to face more than the outer boroughs.
No, thank you. I mean, it does suggest that when this is over, when we've got some time to breathe, that we really, which we talked about already, we really do need to ramp up our education to the borough of why it matters to get a flu vaccine, because so that people are less.
The issue is not education, Ben. People don't believe in the vaccine, and it's got a lower protection, and they don't believe it works.
I'm not sure. Okay, well, since we're having a chat among friends, I don't think we've done the work to know why they're not taking up the flu vaccine. I think we talked about this last time. We need to do the work. We're learning masses, which you're all touching on, and we'll touch on more. We're learning masses about why people don't want to have the COVID vaccine. I think it's not similar to the flu vaccine, and there may be other reasons, but we really need to delve into it more and not make assumptions. That's the one message I'm getting. I found some of the things I've learned have really surprised me, shocked me, and upset me. The things I didn't know. So I think we need to deepen that understanding And
so that I find that really interesting, because as a clinician, I've not really heard anything about any of these vaccines that has surprised me in 19 to 20 years of delivering vaccinations, children's vaccinations, flu vaccinations. The things that people are saying are not, and I've read the minutes from Bob Claver's meetings, the things that people are saying are not really new themes. They are not things I have not heard people say in the past. But by all means, I realise that you probably see way more people than I do, Ben, so I'll bow to your experience.
Well, we're possibly talking about two different things, but when we have 18% of the bar of the people who aren't prepared to take vaccine from the Caribbean background and 16% from an African background, and some of the things that I'm hearing about people saying they don't trust not just the government and the council, who trust the council, but the NHS. And it goes back to years of treatment, which I want to talk about more.
But Ben, I sent you an email saying exactly that about 3 months ago, saying exactly that theme was being heard on the ground.
So what we need to do today is talk about, and we'll do that after the break, is talk about what we can do about that. Because it's not just recognising, it's doing something about that. It's a truly shocking, upsetting. Can I just at this point welcome two more people who joined us as observers, but please feel free if you'd like to ask questions. Meryl Hammer and Jim Greeley from Save Our NHS in Hammersmith and Fulham. Thank you for joining us. I saw Toby wants to ask a question. I didn't see, I was told. Sorry, Toby.
That's all, Ben, thanks. A couple of things. Just firstly, to reiterate the absolutely fantastic efforts of colleagues working in primary care networks and the local authority to get as many people vaccinated as they have. And I think also just to add that a lot of these teams are pretty tired and have been working incredibly hard for the last 12 months. So I think, really important to note that. I just had 2 points, one just on vaccine hesitancy. So I know Bob's coming to will no doubt speak to some of this when he joins the meeting a bit later. But I just wanted to add that a lot of our staff come from the same community. And what we're finding is exactly what James has described, that you only work through all of this one conversation at a time. And a lot of the issues that make people more reticent to have a vaccine predate COVID by a long, long way. Some cases going back for a lot of their lives. And I think taking the time to have those conversations is not straightforward and is not a quick fix. So I think we're only in the relatively early stages of this. I would really hope that those rates increase over the course of the coming months as people take time to have those conversations. But I think we shouldn't be counting scores just yet. I think we've got quite a long way to go. And then just a very final point, which is I think in the report, it mentions that we don't yet have a mass vaccination centre in Borough. So just delighted that we now do. So we opened, I think, the Novotel, didn't we, last Monday?
Yeah, we didn't up until, when that was submitted, we didn't. That was Monday
night.
But
so that's good news. So I wanted to kind of add that in. And I think we're already absolutely awash with bookings for that venue at the Novotel. And hopefully that'll be a brilliant venue as well for people with limited mobility. It's really centrally located. Hopefully that'll be a great spot to up the rates.
And they've done over 6,300 already this week. So, yeah.
They've been busy, they tell me.
Yeah, no, that's fantastic. I mean, it was kind of, it's brilliant, and you're right to praise everybody that's been involved and has been exhausted and is being exhausted and will continue to be exhausted and saving people's lives. It's a sort of noble enterprise, but it's exhausting and draining, and I think we all appreciate the work that people in the NHS and the council are putting in to making people safe. The vaccine centre was a strange one. I think Linda, we offered to work with the NHS to go out and find a centre. I think we found the Novotel, and no secret you did an amazing negotiation there, Linda. And that was late autumn, I think, early winter last year. And then we heard that we weren't going to get one at all. This is not anything skin off the CCG's nose. CCG wants one. And not skin off their noses, no criticism. CCG keen on having the centre, but we were told that we weren't going to get one at all, and a neighbouring borough was going to get two. So we made fairly emphatic representations that didn't seem appropriate to us. And fortunately, those representations bore fruit. And we now have this fantastic centre, which is extremely popular and being very well run. And I think people are delighted to have. But these things, it's not always a smooth sailing as we like it to be, but I'm glad we're getting there.
And Ben, just to emphasise on that we've been ready to go for the Novotel now for some time. It's actually, the teams did brilliant work to stand it up relatively quickly.
Yeah.
And actually the main issue is we're just waiting for the supply to come online in terms of vaccine that would enable us to, as Sue's described, see 6,000 people in the first week and get them vaccinated. So hopefully we can keep it open for much longer and get lots more work done.
Yeah, brilliant. Linda, you wanted to come in?
Yeah, if I can, just 3 minor points, just to prove we are working together. So Patricia, your answer to the numbers, it's 11,856 people have been vaccinated. The CAN contact centre is also texting people, and an email's going out to people as well. So we're supporting our GP colleagues about how we can get more people vaccinated and understand that call. But as colleagues have also said, there are some people who just do not want it. And you know, we have to respect their wishes. And just to say, just a bit of gloating, we have to gloat together. We have to be a bit, you know, because we don't do this very well together. Just when we opened the mass vaccination site, between us, between all our comms and our hard work and Imperial and CCG and PCN colleagues, we blew North West London out of the water in the first week. We had 100% bookings done on day 2. So that is phenomenal. So, and we continue to have a good response rate. So I think we need to give ourselves, for a change, a pat on the back. We are doing something right.
Yeah, absolutely. I give you all a pat on the back. And, you know, it was the people who were saying that, oh, well, they're not working well in other boroughs, so you don't need one, who were completely wrong. And it's just differently showed again the importance, which we've all learned and we all talk about, of looking at each borough and understanding the local situation and not assuming that what goes in one or doesn't go in one is the same everywhere. But well done, Linda and Sue and everybody for the centre. And let's hope we get more vaccine, which is an issue I know at the moment. But let's hope we get more vaccine and that we get vaccine, I think, equitably and across the borough and between the boroughs as well. Good. Would anyone else like to raise anything about vaccination? Meryl?
Yeah, apologies for being late. Diary confusions, and probably have to leave early. But it may have been answered, in which case ignore the question. But are there plans for mobile units for vaccinations to be taken around particularly poorer areas of the borough, for example, council estates and into community centres where, I mean, for those of us that have been at the Bob Claber meetings, we know that keeps coming up as an avenue by which people are likely to be reached, where you don't have to set up a centre that's there all the time.
So, Meryl, can I come in?
Well, I was going to say something, Sue.
Okay.
Do you want me to say something from a clinical point of view about where we've exactly done that?
Yeah, that would be really helpful. I was also just going to just to sort of preface that with the work that Linda and I and the teams are doing around how we're going to spend, because we've got some additional money coming through North West London and potentially through a national programme that we will be bidding. So they're the sorts of things that we will be looking at as to how we can spend that money to do just that, Meryl, in terms of the additionality around going to people and going to the communities where we need to. But Vanessa, if you want to give some of the examples that we've done already.
So we've already, I think we were one of the first boroughs to get permission to do pop-up clinics. And so we have done, certainly I've run 2 pop-up clinics here at the Bush Doctors to help enable some of our learning disabled residents come to a place where they're familiar and get a vaccine in a place of comfort by someone they know. Well, not that comfortable, the best we can do. And I know that there has been another practice that did a pop-up clinic and reached over 40 people who were in the over 80 category, who were not housebound and didn't want to be viewed as housebound or treated as housebound, but found the journey up to Richard Gate too far. So we have been listening to the needs of our residents and patients, whichever term you want to call them, and accommodating ourselves where we are allowed. But it's not a smooth process to do the pop-up clinics, but we have been doing exactly that, moving things to where there is a different need.
Can I just come back in on that though? I accept all that, and I'm delighted to hear it, and I'm delighted to hear there's extra funding. But I think it's concerning, given the growing body of evidence of those who haven't been coming forward, that this is seen as something that's additionality rather than centrality to what is being done. Just a comment.
But it's not easy to do with the vaccine and the requirements around the vaccine. That's the issue. Because the vaccine can't be transferred and refrigerated. So once it comes out of the fridge and it can only go to certain places, you have a ticking time of 6 hours to use that vaccine within. So you have to move the vaccine once you've got your clinic booked, and you need to use all doses of the vaccine. So you need to make sure that you've got no DNAs. So it's quite unique. It's unlike any other vaccine that I've ever worked with, where you can transfer them in a cool bag and then give them, put them into a fridge and use them at leisure. You haven't got that luxury with the AstraZeneca vaccine, and that is the only one you can move off site. The Pfizer you cannot move off site. Sorry, I've forgotten to put my video on. Sorry.
I just need to interrupt you all for 1 second, just to say we've coming up to an hour, and I just aware of the Palantine piece. So we'll have another 5 minutes on this, and then have a break, if that's okay. Is that going to be okay, Jane, with you and Jean? If we have another 5 minutes before a break? Yeah. Okay. Great. Thank you very much. So Jim, who else was? Sorry, I've lost my track of who else was wanting to come in there. Meryl, you came in. Did anyone else?
Councillor Jim has his hand up.
Right, thank you, Jim.
I'm very impressed indeed by the remarkable take-up at the Novotel, and well done to all the team. Just one observation as a long-term local, I noticed the local parks are now filling up at the weekend, thanks to the good weather, and may it continue. The borough has used, in my view, very effectively, electronic test boards, get a test. And I'm wondering whether they could be adapted to say where clinics are, to move them to parks at weekends, so that the culture of expecting people to take the vaccines is actually seen by large groups, including families, older people, young people. And I do notice my local park, for example, Bishop's Park, end of school, packed with people, with parents and children. At the weekend, hordes of people there. And I think the use of resources by the borough, which really has been good, you could probably adapt that to talk about vaccine centres, so people are prepared where to go. That's just an observation from walking around daily.
Thank you, Jim. Linda, can I bring you on that?
Yeah, thanks, Jim. I think that's a really good idea. And we are using the dot matrix signs also to show people where the mass vaccination centre is. The difficulty we've got here, we've got a balance of, we've still got priority groups to vaccinate. So at the moment we're 50s and over, and people who are carers. And what I don't want to happen is a general message to everybody about getting a vaccination, because we've actually got crowds turned up at the Novotel the other day thinking, oh, I can get a vaccination, or I don't want people ringing the GP and say, the council tells me I can get my vaccination. And then, you know, so I think we just need to be, I think it's a really good point. We're limited in the amount of text we can have on those boards, but I will look at, say, a message over 50, get a vaccination, something like that, I think would be good.
That would be good. I think that's a good idea. Thank you. Okay, so we touched on the we touched on vaccine hesitancy, and we touched on which will lead us into the next item. I think if we take a break now, we can pick it up then, and have a good conversation about what we can actually do. So a break now. Jane, I'm being informed here. Would you like would people like 5 or 10 minutes break? That's not just Jane, but would people like 5 or 10 minutes? Any views? Partly Jean Goff, I thought your view. Linda, what do you say? 5. Everyone's saying 5. Is that all right, Jane? Can Jean bear that?
And just a reminder, Chair. Chair, if people cannot leave the meeting, place your mic on mute and shut your camera down. And when you rejoin, obviously open up again. Thank you.
Sheba, can I leave the meeting and rejoin so I can get home? Otherwise, I'm going to get locked in the building.
I'll do my best to get you back in.
I'll rejoin as soon as I get home on my PC at home. Thank you. I'm going to cycle home now. Thanks.
Okay. All right. We'll see you all in 5 minutes then. Thank you very much. Thanks. Okay. See if we can bring everyone back bit by bit.
Chair, Councillor.
Yeah.
It's Bathsheba. Jean's just texted to say she needs a full 10 minutes break. I'm sorry she didn't get a chance to say that earlier.
That's what I was trying to check, and I understand
Yeah,
that.
no.
It's the normal thing. Okay, we'll take another 5-minute break then. Okay, we'll have another 5 minutes now. Thank you.
I'll monitor people coming back.
Thanks very much.
Bathsheba, are you there? It's Nikki.
Yes, I am, but do bear in mind this is still live streaming.
That's okay. I'm just going to quickly send you an email.
Okay. Chair, Jean is ready.
Good. Okay, well, we'll come back together then. Let's see. The paces pop up. Jim and Meryl first straining at the leash. Patricia, Philippa, Linda, Toby. Linda, am I as quiet as a mouse or a little bit louder now?
No, it's louder now. Thank you.
Okay. I did something magical with technology. Yeah. Good. Okay. I was just trying to find out where Bob Claber is. Wonderful Dr. Bob. But he may join us in a minute, I guess, Linda.
Yeah.
Okay. Okay. Well, I'm going
to past, Ben. So you should be online in 3 minutes.
Oh, fabulous! Oh, fabulous! Okay. That's really good. I appreciate people. You know, particularly people in hospitals. You're all. Well, is he in the hospital at the moment?
Mm-hmm.
Yeah. So, unless you've got a hospital background mocked up, like, you know, I'm not actually standing in front of the town hall. So when I see Bob, he always seems to be in a hospital. I just thought I'd check. I was just saying before the break, a big issue which may not be news to some, so I'm just going to talk for me, is, and it's really been sort of shocking and surprising, is how many people are reluctant to take the vaccine. And when we've done a lot of analysis of the figures, right down to ward level, we've looked at ethnicity, and we've looked at income, among other things. But we've done a lot of analysis, and this I say we, this is the health and care partners together doing this analysis. The council has been number crunch. You've got a great business information service, which we're all working together to use. And it's quite clear, and this is no surprise because it's the case across the country, that some people from a Black and ethnic minority background are among the most reluctant to take the vaccine when people are not taking the vaccine. And the conversations I've had, and I appreciate we can only go on conversations we've had and they don't speak for the truth of the whole world, but the conversations that I've had have been that people don't, crudely, they don't trust the system, they don't trust the government, they don't trust what they're hearing from government or the council. Why anyone should want to trust me, I don't know, so I can understand that. But when I hear that they don't trust the National Health Service, which is what we've been told, I've been told, and I've heard this from different people, I've heard this from our mayor, who spoke to people who were reluctant to take the vaccine. She's Nigerian origin, she speaks to friends, and she hears this. I've spoken to people who are of Caribbean origin, and the issue that comes back again and again is this is not a problem that has suddenly arisen. We're seeing a manifestation of a problem that has been building for years. And we talk a lot about inequality, and I've used the term inequality here because it's a term we're familiar with. But I think we also may want to talk more about race and about the issues around that and understanding what people are really thinking. And it might be partly religious reasons, but I feel that there are some deeper reasons about how people, hi Bob, nice to have you here. Great to hear. There are deeper reasons why people do not trust what they've been told about the vaccine and are uncomfortable to take it. And they're to do with many years of the system not being seen as fair for them. Now, that's a fairly challenging way to begin. I'm going to, we've got three sort of, we don't have to have presentations, but three people I'd like to bring in at some point, as well as all of you for a conversation. Bob is going to talk about some specific work we're doing in the area of a huddle that's taking place with Linda and other people and lots of people across Northwest London on looking at getting people back, how we can working on getting people vaccinated is perhaps how it began. Bathsheba has been leading some work the council's been doing, reaching out to community groups, and I thought it might be useful just to run through who we've been talking to so far at some point. And Nikki Lang, Dr. Nikki Lang, has taken forward our existing commitment to implementing the Public Health England report into health inequalities around COVID. But I wonder if I could start with Bob, if you wouldn't mind, Bob, just to talk about the work you're doing and contextualize it, explain what's happening, what the aims are, where we're going.
Thanks so much, and really lovely to be with you all, and really grateful for the invite. Sorry for rushing from one thing to the next. The slight story of everyone's life at the moment. So I know lots of you on the call, but for those of you who don't, I'm Bob Claber. I'm a paediatrician, and I'm the Director of Strategy, Research and Innovation at Imperial College Healthcare. And also I sit as one of the clinicians on the proactive population health and inequalities group within the integrated care system. So tiny bit of background on that. That was set up in August time was when it first started, and chaired jointly by Carolyn Regan, Chief Exec of West London Mental Health Trust, and Niall Bolger, Chief Exec of the local authority in Hounslow. And I think one of the things that group was very successful about from August time was bringing together colleagues from local authorities, what I would call sort of real community leaders, a number of people on this call who've been, brilliantly active in trying to improve the health and care system within North West London, and NHS people. And we came together, and we've been doing lots of sort of exploring of things we might want to really focus on. And then rather amazing news started to emerge in November, December that, vaccines were going to be a real thing. And you couldn't quite believe it, that they were actually landing and coming in people's hands. And in the very early days of distributing vaccines, this data started to show that there was these disparities. And so really trying to move quite quickly in January time, one of the observations I made was that there was quite a lot of good pieces of the jigsaw, and there was a lot of work going on to practically deliver vaccines, and there was lots of work going on around communication and engagement about it all. There was a lot of work around thinking about data and evaluation, but perhaps we hadn't necessarily created a space where we could bring together people who were responsible for the practical aspects of this, people who were working within local authorities and boroughs to try and improve vaccine equity, colleagues from across the NHS, particularly GPs working in primary care networks, and other people working out as community leaders in neighbourhoods, in churches, in places where people go, and among residents. And we thought, could we try and use some improvement methods? And I set up the improvement team at Imperial about 5 years ago. And so Hannah Fontana, who's a wonderful colleague of mine, and I said, look, we're happy to put in a bit of time to help support this, and teamed up with wonderful people like Linda and Samira Ben Omar, who many of you will know, and colleagues within the integrated care system to say, let's create a series of 10 weeks of these huddles where the idea of a huddle is a sort of weekly, hour-long space where we can bring people together and we can genuinely co-produce tests of change, things we want to go out and try. We can hear from people. We can do that sharing of learning. We can find out what isn't working. We can try and sense make what some of the data is telling us through more qualitative work. And we're halfway through that. So it's quite a proven method. Sometimes people call it 90-day innovation cycles or 100-day innovation cycles. And we've been rattling along through these weeks. And I'm going to just put into the chat a link to the website. It's quite a simple website, but on it you can get the packs for this huddle. You can also get the Teams link for the 6 till 7 call. Now, I hardly need to advertise it to you, because looking at the names of the wonderful people, many of you have been to many of the huddles already. And I think the final thing I really want to finish on, Ben, is this piece that you started in your introduction. I think there's a load of, practically all of us on the call have been shocked and deep learning about some of the reasons why people are not coming forward and saying, no thanks to the vaccine. And it's not necessarily about a technical thing about the safety or effectiveness of the vaccine. It's a much, much deeper issue around structural racism, around a feeling that the NHS and the wider health and care system has never been interested in them before. Why are you suddenly interested in us now? A deep mistrust of research going back over decades. And they're the stuff that all of us on a health and wellbeing board, we're passionate about improving the health and wellbeing of our residents, of our communities. Unless we properly understand this issue around trust, this issue around racism, we've got no chance we'll be doing stuff that just fiddles around the edges. So I think it's been quite a deep moment for all of us, and it's been a real privilege to sort of think that through together. And I think we're in the very early stages of trying to understand that. But I think there's a growing and collective determination that there's no stepping back from this. And, you know, I can speak personally, and everything I'm going to do to try and influence people around me is that we continue to deepen our learning, and we've got to do that together. That has to be with our communities. That has to be the NHS, local authority, in partnership together. How do we really go forward with everything we're doing across the health and care system with some of these methods, with some of these approaches? So I think I'll probably sort of stop there as a bit of a context, but I think I want everyone on the call to sort of realise, I think this is a really important moment that has a 10-year projection, 20-year projection ahead around it, about how the NHS in particular, where I sit and come from, that it's called the National Health Service, but it's been largely focused on illness over 70 odd years, and generally, you know, does a pretty good job, but hasn't really got its head around how to do the health and well-being bit. We've got a moment now to partner up in a very different way, to show a humility and a learning and a different set of trust, and to achieve some outcomes that we're yet to achieve in terms of tackling some of these inequalities.
Thank you, Bob. Thank you very much. I agree completely. Thank you for setting it out so well. It's a lot for us to think about. I just wanted to get some first thoughts and first reactions from people to what we're trying to do. I mean, just to address, if I may, what, you know, Bob, what you're saying is about people saying, so why me now? Why are you focusing on this? Has come so clearly out of the call. I think the fact that we've been prepared to talk about the fact that there may be people may be suffering from years of racism in the society, and that's coloured their thinking, I think is something which I feel strange. I felt strange talking about it, and also talking to Black colleagues and people from different ethnic backgrounds, because we just don't do this, and we tend to use the phrase health inequalities in this slightly pussy-footing way. And when our Kim's not here, but when our chief executive met a nurse leaving a meeting, socially distanced, the other day, she bumped into someone who happened to be a nurse, who happened to be Black, and she said, they talked about vaccination, and she said, are you taking a vaccine? She said, no, I'm not. Why not? Well, because I know there are going to be 3 vaccines, and they're going to give the worst ones to Black people. And you know, you may think what you don't think it from what I don't take away from that is, oh, how silly. What I take from that is how horrific that somebody should think, as you said, Bob, 70 years after the foundation of the NHS, 65 years or so after since the Windrush, how people should think like that. This is how the system thinks about them, and they should feel this. And I felt a great grief, this learning how many people are allowed to take the vaccine, and how much of that to do. Some of our mayor was talking to an older gentleman, a retired man from Nigeria, and he said, I'm not going to take it. They just want to kill us with the vaccine. And she said, well, if you don't take it, Mike, he said, I don't care. That's what they want to do. And she's trying to have this discussion. And you know, we can't pass over, as you say, Bob, the opportunity to look at this really honestly and not take this is just about sorting out vaccine reluctance, so all the white people get vaccinated, so everybody gets vaccinated, so all the white people are safe. Very crude way of putting it, but I think we have to grasp the fact that there is this massive space between how we think a lot of society perceives the NHS and perceives health, and what we've actually learned through COVID is the case. And it's a great opportunity for us to really improve things now, and I'm delighted that we've got people together. So I'd just like to get some views and some initial thoughts on the sort of things we can do, or if people just want to share an experience they've had of where they think the system is absolutely unwittingly and unintentionally doing things which might be perceived as racist. Just come in and say those. I mean, I'll chuck some things in, but it'd be good to hear from other people.
Chair, Jim and Patricia have hands raised.
Thank you very much. Jim and then Patricia.
A smaller point and perhaps a bigger one. The smaller one is on racism. For many years, I worked in a local secondary school managing people. Once a year, we collected data on all students. It was compulsory from the Department of Education, including asking people where they came from, what languages they spoke. The school was well run, well trusted. The students felt at home there. That was one of the few occasions where there was reluctance or conflict between students and staff, and also among the staff. Now, I myself am a white immigrant, but people would say, young people who are smart, who I think trusted me and the school, would say, what are you why are you looking for this? What's going to happen? That happened only from people who were darker skins, if I can put it like that, who were like me, were often born here. I'm Irish, I'm not British, but it struck me because I retired some years ago that that kind of experience is being reinvented constantly because we live in the middle of the hostile environment. Windrush hasn't been solved in any way. So very many of our citizens who are British, but who have got darker skins, may well feel day by day there's a renewed questioning of their right to be here. And one thing I think that we could say is that when people go for vaccine or go to clinics, I think we need to make it clear their data is safe within the National Health Service. It's not going to go elsewhere, because there are far too many of our fellow citizens actually are not certain that that is the case. And one tiny footnote of this, with somebody else on screen, only some years ago, I went to a very good local hospital. I was sitting in A&E with her. That's with Meryl. Meryl, like myself, is an immigrant, white. A man came in, quote, with darker skin, and the woman at the desk asked him where he came from and did he have identification? And he said, listen, love, I was born in White City. He named the school and the teachers, etc. And then he said, have you asked anybody else that? And of course, the woman hadn't. I suspect many citizens who come from elsewhere are challenged far too often in that way, accessing health or education or other state services. And with that, I think the safety of data has got to be assured to people so that we're not going to pass it on to people they have only too good reason to mistrust, even when they're, like myself, they're entirely British.
Thank you, Jim. Thank you very much. And I'll bring Patricia and then Meryl and then James.
Thanks, Ben. So my parents were Irish, and I remember it's just something my mum told me when I was very young, and it's always stuck with me. No blacks, no dogs, no Irish. Now, we're in 2021, and over the last few months, I've been hearing these horrific and actually very upsetting stories about racism against the BAME community. It has definitely got to stop, and the only way, one of the ways that we can move with it is to talk about it, to talk to people that are being affected, ask them what they want. How do we go forward? And as dreadful as this pandemic has been, maybe this is a small part of it is the way to tackle racism, because it's a horrible word, but we've definitely got to tackle it. And Bob, just to say that I really enjoy coming to the huddle every week, and I've learned so much from it. But I really, I've never forgotten that phrase my mum told me, and I'm just horrified that in 2021 we're still having to tackle racism, and it's shameful.
Okay, thank you very much, Patricia. Meryl.
Unmute. Yeah, what Bob has said is really important, and what you've said, Ben, is really important, and fully agree with Jim. Would I dare disagree, and Patricia? But I want to suggest as well that in some cases we need some finer discrimination. Yes, we're hearing strong messages that people from certain communities are talking about not trusting the NHS. But I don't actually think by and large it's the totality of the NHS that they don't trust. I mean, the messages we're hearing and what we're seeing in terms of the vaccine is that there's a much greater trust of those parts of the NHS that they know. Their GPs, for example, there's much more willingness to see a GP or to go to a GP practice that they know in order to have the vaccine. They are, and our experience as a campaign, and I think this is quite important, is that people from a wide range of minority ethnic communities, as well as white working class people, were hugely willing to take leaflets from Hafson, to sign our petitions in order to save their local hospitals. Hugely keen to do that. So it wasn't that they didn't trust their local hospitals, but what they didn't trust were, quote, the NHS bosses that were trying to remove the NHS services from them as local people. And I think it's right. I think it's quite important that we bear those distinctions in mind as we talk about how we can reach people from different communities, because where local services are actually matters to people. And if services are removed from where local people are, or if they're seen as distant and in some way unapproachable, then they'll be viewed with suspicion. So while it's important to say there are suspicions about the NHS, they don't trust it, I think at the same time, we've actually got to then analyse what is meant by that statement.
Okay, thank you, Meryl. James.
So I just wanted to sound a more hopeful note in some ways. We are now in an era where we're finding through data analysis that there is unconscious bias within the services that have been set up by the NHS, and we're trying to address that. In July, I was involved in some work with the Royal College of Obstetricians and Gynecologists that had published data showing that you were 5 times more likely to die in childbirth if you were from West Indian descent, and twice as likely if you were from Asian descent compared to if you were from Anglo-Saxon descent. And looking at that, it wasn't just because of the long-term health conditions that were more prevalent in those communities. It was due to inherent attitudes within the departments where the data was coming from. And they've subsequently set up a task force to try and get underneath that data and understand it. So though we're horrified by what we hear and what we find out in individual conversations with individual members of the public, we are in an era where through transparent data analysis, we are starting to identify these issues and then move to address them. So I'm much more optimistic about this than I was when I came into the profession, because we simply didn't understand how the structures we had set up were unconsciously racist or biased towards some sections of our population. So I am just trying to sound an optimistic note that we're pulling this stuff out into the light and starting to address it.
That sounds positive. Thank you, James. Toby, you wanted to come in.
Thanks. Yeah, I'd like to share James's optimism, and not just because I work with Bob, but I think because there are some genuine reasons to be optimistic, especially in Hammersmith and Fulham. So I guess I want to say a couple of things. First of all, that I think it's fair to say that the answers to tackling these issues are not going to come from this board, in the sense that it's the community that will teach us about this. And I think there's a degree of collective humility for boards like this and for big organizations like Imperial, etc., about how we tackle this, recognizing that they're incredibly complex issues that, you know, stem from a whole series of kind of long-standing historical factors. So there's a bit of humility in terms of the first bit. The other bit I wanted to say is in terms of how we engage with complexity, one of the things we've been doing with our charity is looking at how we can repurpose funds that were raised for the purposes of supporting healthcare to see how we can support communities affected by the pandemic. And specifically, those communities most affected by the pandemic, which are also those that have historically poor health outcomes and suffer from the kind of worst consequences of health inequalities. And what we found, it was a North West London process, which is just concluding at the moment. And the specific plan was to look at distributing some grant funding to grassroots community-based organisations to try and impact on those communities most affected by the pandemic and start to address some of these complex issues around health inequalities. And Hammersmith and Fulham was disproportionately represented in the bids that came back, because I think it's fair to say there is an absolutely fantastic voluntary sector set up in Hammersmith and Fulham. There are some absolutely brilliant organisations, and also quite fragile organisations, especially at the moment. And I think I can't tell you exactly who has been successful in bidding because I'll get in a lot of trouble, but we'll be able to tell you in a couple of weeks. But I think we've agreed that I think we'll be able to invest about £200,000, maybe £190,000 in 9 different grassroots organisations in Hammersmith and Fulham, who actually can start to address some of these complex issues around health inequalities, and in doing so will teach us a huge amount about how these things work and don't work. So really happy to come back and share a bit more of that. And as I say, once I can tell you who the organisations are, I think it'd be great to connect with Linda and Sue and others on this board.
Toby, that's really good. I think you're quite right. You know, a load of us sitting around here isn't going to solve it. We can, however, have a commitment to solving it, and that's what I think we already do have. But we have to. It's even more real than when we first started talking about the report last year. Can I just bring in at this point? I think it'd be interesting, Bathsheba. You just talk a little bit about the outreach work that you've been leading for the council to try and talk about vaccine. What you have, who you've approached, how that's worked, and the sort of comments that people have made to you about would and wouldn't work in talking to groups, and who should do the talking and who shouldn't, and so on, and where you've gone, just to give a flavour.
Sure, happy to do that, Chair. So since February, we started organising a series of engagement events. The impetus really has come out of discussions that I've had with myself and Linda and Councillor Coleman. We were really looking at what we could do to kind of understand why people were lacking in the confidence in taking up the vaccine. And we thought about this quite carefully, because it struck us that whilst we wanted to talk to as many people as possible, there were ways and means in which this could be done successfully. And we realised fairly quickly that local small events would work best, because they were able to offer a level of assurance that wouldn't necessarily be possible in larger scale events like a webinar. Those work extremely well. They give a lot of information, a lot of detail, and that's fantastic in terms of their reach. But in terms of actually speaking to people, in terms of offering a level of insurance, understanding where they're coming from, understanding what their concerns are, what the issues are, and as people have already touched on and recognised, there are layers of complexity, and they all link to social historical reasons as to why people are so reluctant. And everyone has a personal view, a really personal view as to why they are reluctant to have the vaccine. And no amount of webinar is actually going to understand that. So it really does take a local conversation, and that's the conclusion that we reached. So on that basis, we started talking to local organisations across the borough. We talked to people like Sobus, Nubian Life, Association of Somalian Voluntary Organisations, and we were finding that they were really keen to have these events. So we started organising them. We've had some brilliant support from local clinicians, people like Bob, James, and so on. And they found these sessions empowering. They found them valuable. They've had a clinician in front of them that's been able to talk to them about what's worrying them. They've been able to ask the burning questions as to, will it affect my fertility? People have tested this on Black people, Nigerian countries, even as far back as the 1990s, they were still conducting tests in Nigeria. So we were hearing all these stories and finding that the more that we worked with the groups, the more we found that there were layers of complexity. And the feedback that we've been having from not just voluntary organisations, but faith organisations as well, and I mean all faiths, so Anglican, Methodist, Muslim groups and so on, what we're finding is that the feedback has just shown us how much there is a need for these types of conversations. We've been successful in having, so far, we've had about 12 events. We've had 6 more confirmed to take place. We've got 3 in the planning stages, so around 21 in total. They range in terms of the participants from as low as 2 to as high as 34, 35. And we've got, just recently, we were approached by the Diocese of Westminster to hold a webinar for the entire North London area, which is a pretty big undertaking, and it is very, very different to the types of events we've been running. But we found in working with the diocese, they really liked the approach that we've taken, because we've constructed a webinar that's really based on a very sort of loose structure of the issues that we've already identified, and then interspersed with Q&A questions coming through the live webinar. So I'm looking forward to that event taking place on Saturday. So I'll stop there if anyone has questions.
That's really helpful. Can I ask you just a little bit about the people that have spoken? And also, I remember Mercy was happy to go and speak as a councillor. She's Nigerian, 30 years here. She's our match. She was a former mayor. She was happy, Mercy, in the council to go and speak at one of the events at one of the churches, and advised. Well, what was the advice you were given? And generally, what's the advice you're given in terms of who the speaker should be?
What we're finding is that the advice that we're giving is we're trying to make the clinicians as representative as possible. And I'm sorry, I'm realizing that I've gone quite dark here because the sun has gone down since we started. We did have some concerns, 2 things. One, we didn't want to stigmatize in the sense that, you know, we're focusing on particular groups. We're not actually doing that, but what we are trying to do is make it representative. So people will naturally find it easier to trust someone that they have an affinity with, and that's just a human fact of life. What it does do is help support the level of assurance that we can achieve out of these events, and the more representative our clinicians are, the more likely it is that we are relating to the person in front of us, and that can only bode well for the outcomes. It's really difficult to give a definitive idea of what the outcomes are going to be, because we can say, you know, at the start of the event, did you think you might not have the vaccine, and then at the end of the event ask the same question, but it doesn't necessarily mean that answer will remain the same, because people can change their minds. So it's very difficult to try and sort of evaluate the kind of response.
Thank you. But the essence is we're going out into the community, and this is being run by the community. And when we offered a counsellor, when Mercy offered to speak, the feeling was that, you know, she may be black, but she's
absolutely
not going to be trusted because she's
absolutely. It was really sad, actually. She's got an amazing amount to offer, but unfortunately there is a perception that perhaps she's been coerced into supporting the vaccine, and that just then has the opposite effect of what we're trying to do, which is really unfortunate.
Well, thank you. That's really helpful. Would anyone like to pick up on anything that should said, ask anything, explore anything? Any lessons it might give us that occur to people for what we do as a whole community going forward? Because obviously we're addressing this. What we've done there is a vaccine thing. I've got Bob. You put your hand up, and then Jim.
Thanks very much, and thanks, Bessie. But I think just really briefly a reflection, and you know, as a white middle-aged middle-class doctor who, you know, has been well trained at taxpayers' expense and all sorts of things. I think the sort of humility point that Toby and James pointed out is really, really important. And I think the experience I had on that sort of the Friday evening of doing the We Co-Produce work with focus particularly with the Somali community, it was this wonderful, it's just getting that sort of mix of people. I think, you know, the 3 of us who were doing that together, and it was a good, you know, decent space of time. We were able just to bounce off each other and give different perspectives on that. I'm quite close to some of the research side and can bring some of that, and can bring a perspective of being a paediatrician. But there's a whole lot of stuff I can't bring a perspective of, and I thought the colleagues who I was with were brought a legitimacy and a closeness to the community who we were talking to, and it was a real privilege to be able to do that. So there's something as we go forward, you know, thinking beyond vaccines as well. How do we do this stuff in teams more? You know, the idea of the sort of very wise, inverted commas, expert. I don't act that out very well myself, but you know, that stuff just has sort of, we've got to move on from that. And that was my reflection on this. This is a team approach. and thinking really thoughtfully about our teams, and having people who've got expertise in the community really understand, help people like me to do our jobs better. So that was my reflection of that. It was a real privilege to be part of it. I'm sure I learned as much as the people who we were trying to share things, and I think that sort of approach that we're on it's a conversation, this is about learning together, feels really important.
Yeah, no, absolutely. No, thank you for that. I mean, learning, I have to say, I saw this, forgive me for jumping in, but none of you might have seen David Harewood's documentary 2 or 3 weeks ago. I can't remember what it was called, but it was something, not quite being black make you ill, but it was a really shocking documentary. And some of the stories, when this woman who'd lost her daughter who was pregnant, and the doctors were not taking it seriously and said, well, black women have a different shaped cervix, and well, black people can bear more pain. And some of the stuff that's coming out is just, from now, just horrifying. I mean, really humiliating and shocking, and we just don't know. So I think, Bob, hearing what you're saying, you talk about humility and learning, we just need to listen and get people's actual stories out there. And I think we're at the stage now of saying we need to listen and get the stories out there. We need to work out how we move into that, and then into how those stories change the way things work. I'm going to bring in Vanessa. Well, Jim, I'm just going to bring people who haven't spoken yet. So I'm going to bring Vanessa and then Philippa, if that's okay.
So I was going to touch on this, and the irony that actually what I can see on my screen is a sea of white faces talking about black people's problems is not lost on me. And I'm really pleased to hear Bathsheba talking about this. Sorry, Bathsheba, but it's nice.
Maisie's with us.
Different ethnic background talking about problems that are felt. One of the things that I was going to touch on is this is exactly been my concern about nurses who work with vaccinations, who come from a BAME background, who have been resistant to having vaccination. And we know that that has been a problem for our workforces. And I know that that's been a problem for CLCH, or not a problem, but a challenge within CLCH. And it's been a challenge for me within my own smaller workforce. I am pleased to say that now all but one of my nurses is vaccinated, and I have had to work extremely hard on them. And one of the reasons why it's important to me that they're vaccinated is obviously I want people to be safe in their workplace, but also because they are an advocate about vaccination themselves. And there is nothing stronger than having, as Bob has just identified, and Bathsheba, than having people who come from a background that you recognise and respect, speaking about vaccination and talking about your fears and concerns. So the more that we can have people who are seen as kind of experts within their own areas, and I don't mean medical areas, I mean areas of community, the better that we will be at trying to get the messages out there. And I recognise, and I feel the same as Bob, being a white middle-aged woman, I can do some work. I'm not saying that I cannot do work, but sometimes actually I can't understand where people, I can hear where people are coming from, but I'm never going to feel what that feels like. And having other people who can understand that and empathise with it and talk about the issues is much more powerful than I can be. So I'm very pleased about my nurses because they have really worked hard to change their views and be vaccinated, and it's made a real difference. And it means that I then have confidence when they're dealing with other vaccination issues like flu, like baby immunisations, for whom we have similar target, hard to reach target groups, that actually they can be really effective in how they promote vaccines locally.
That's great. I mean, it's also important as we move this forward to make sure that everyone's getting vaccinated, but also to say, take this as an opportunity to address the really major issues that led to people not wanting the vaccines in the first place. And it's helpful that we can make progress, but that's something which we need to do more on. Philippa, you wanted to come in there. Maisie, I don't know.
Yeah, thank you. Yeah, I think that's a brilliant segue. So I think that's a fantastic segue into the next item, actually, about the ICP, which I do hope we've got time.
Goodness me, you're quite right. I'm sorry. Yes, thank you for the reminder.
But before we do that, there's a couple of items on this which I think has really struck me through that conversation. And yeah, I think as a community trust, we have experienced exactly the issues that have been talked about, and our staff are obviously out there in the community, working with these communities every day. So as Vanessa alluded to, we have had to work really, really hard to get some of our BAME staff taking up the vaccine themselves, and my division has 60% BAME staff. We are at an 80% vaccination rate, which is higher than we've ever seen for flu previously. So similar conversations to those ones earlier about the general population. But these, as Toby said, the workforce I have is the local population, and they report the issues that they see with the populations as well. So I think we are doing really well. CRCH is right at the top of the leaderboard in terms of NHS trusts and getting our staff vaccinated, so that's really good. But it has been truly a hard slog, and to do individual conversations in depth to get that level of uptake. So, but I think going forward, I was really energized by Bob's presentation, and I think we've taking all those principles around hesitancy and around vaccinations and what's going on there really into the integrated care partnership to be approached really broadly in everything that we do. So I just wanted to flag that before we go on to that item.
Councillor, you're on mute.
Sorry, I'm on mute. I'm sorry, mute. Sorry, I was going to say I'm going to bring this to close in a couple of this bit in a couple of minutes, and then we'll move on to the integrated care partnership. Mizzy, I wasn't sure if I saw your hand up.
I did have my hand up, Chair. All I wanted to add was I think that the work that's been undertaken in the borough from an organisational point of view, which is an organisation that represents the views of local people, is really very impressive. I think the fact that the borough is willing to listen, the conversation that Bob has in those huddles is something that to be really appreciated, because it's really showing that the organisations actually want to listen to what's going on for people, understand their views, empathise with those, and try a plan of action. The concerns we have from Health Watch is so much has changed for local people. They don't want things to remain the same. That's what we're hearing. They don't want things to stay the same. It will be dreadful if things go back to what they were, knowing what we know, and we haven't done anything different about it. So the steps that are being taken, I think, are being welcomed. We at Health Watch do have some local virtual webinars that we're undertaking that also are trying to understand what's going on. And all we're hearing is, please don't let things go back to what they were. We can make a difference.
Yeah. Well,
and so that's, yeah.
That's incredibly helpful.
Really,
it's a very good place to move on from.
No problem.
It's really, this is not about vaccination. It is about vaccination now. We've got to protect 100% of the country from getting ill, if they crudely, and worse. But it's not really about vaccination. It's what I think, Maisie, as you say, it's these issues are finally being raised because of COVID. It's a good thing they're being raised in the middle of the horror of COVID. So the fact that you're all here determined, and we're all determined to do something more about this. And Nikki, I know you were going to come in and talk about the work you've been doing on implementing the Public Health England report on inequalities, but we're going to have to hold that over, and apologies, until our next meeting. But Bob, we're all very excited by what's coming out. I think the big message today is we need to get people who are from ethnic minorities together, talking about actual crap things which happen, and turning that, along with the motivation we have to make things better and the humility that you and Toby have talked about, into actual policy which changes things, so we win trust and we never find ourselves in this. There was a major, an army major in your meeting yesterday, who said he had been truly shocked, and he said, by what he'd heard, and he said, and I want to say I was very upset, he said, but I want just upset, I'm angry that this situation should have arisen. And I'm feeling the same, you know, of a certain age, white liberal, and we're hearing the stuff that we've been hearing is tragic. So I feel very enthused, and I think we all must, by what we've talked about today and our determination to move forward on this, and we'll come back to this. Now, I have to make an apology at this point to Jane and to Jean, because we are going to talk about the integrated care partnership, and I know that Jean, you have to go at 7, and so Jane, my apologies. This is an example of pathetic equality not in action. I'm afraid that it means you won't have a panel typist, and it's probably quite difficult to lip read, I don't know, in this virtual meeting. So my apologies, and it's very difficult for me not to ramble on, but then I have to remember, I think in future, not to let meetings ramble. I have to remember in future that it's actually, I'm limiting the participation of people in an unequal way, so I apologize for that. But I'm grateful for you coming. I hope you'll come back. I hope you won't be put off, and I hope you'll come back again. Yeah, thank you so much. Okay, well, I would
like to attend again, if I may.
It would be a great honour for us all if you would. You've contributed. I mean, Jane, just to say, you've contributed so much for disabled people, improving the lives of disabled people in the borough. Our town hall is going to be the most disabled-friendly building probably in Britain when it's actually finished, and all the other things that you're involved in doing are making a real difference to people's lives. So thank you, and thank you for coming here today. And my apologies again.
Yeah, Chair, Jane, I was just going to say that we can always have a catch up outside of here about the Integrated Care Partnership, so not to worry too much. Okay.
Okay.
Let's do that. Okay. Thank you so much. All right. So we're going to talk about the Integrated Care Partnership. It's the Larry Whitty. Hang on. Jane? Do you want to say something? No, she's going. Okay. What's his name? Whitty.
Chris Whitty.
Larry Whitty, who all of you will remember fondly as the former General Secretary of the Labour Party, was the name I had in mind. Chris Whitty said something really interesting yesterday. One of the many interesting things that man says. The Prime Minister was busy going on about greed is good when it comes to the vaccine. Chris Whitty says something a bit more interesting, which is he's really worried that the amazing coming together of health and councils and social care
is going to be lost.
Is going to be lost. And so I'd like to talk. That's what we mustn't do here, because we are really building on wonderful things. So I want to give you, Philippa and Lisa, a chance to talk about the Integrated Care Partnership and what the aim is, the context of it, and the aim and where we are and where we're going. And
okay,
I'm sorry, we're running a bit over time. So I'm thinking if we allow 20 minutes for this part of the discussion, would that be okay with everyone? If it goes longer and you want to stay, then yeah, does that sound reasonable? Or perhaps we could have a bit longer, Lisa. What do you think?
I think we can cope with that, and I can be brief in terms of introduction. So shall I make a start, Chair? Is that okay? So great discussion to introduce the Integrated Care Partnership, as Philippa said, and hopefully, and I'm conscious of time, so hopefully everyone's had the opportunity to read the very brief paper giving an update on the Integrated Care Partnership, or otherwise known as ICP. And I think the discussions tonight have really fed an awful lot of what the ICP's about and what it's going to be about. I think the key, Philippa and I co-chair the Integrated Care Partnership, and I think over the last few months, we've been trying to reset. I think we're a bit through the norming and storming stage now, and we've managed to look at some draft priorities. So the key points I wanted to make is we've identified 5 areas for focus for the Integrated Care Partnership. Staying well, and these are all in the report, so you don't need to write them down. Staying well, living with mental health, recovery, and ICP PCN development. And I think the 4 emerging immediate priorities are diabetes, frailty, mental health, and health and well-being. And a lot of what we've been talking about tonight, I would say, is completely implicit and explicit in what we need to do and achieve. And I think, as Chris Whitty said, and as you've just drawn our attention to, Ben, absolutely key is building relationships and building trust. And we had a workshop earlier this month to help us with that. I think what Chris Whitty referred to as not losing what we've developed over the awful otherwise awful year that we've all had. We don't want to lose that. We've really, we can see tonight, we've gained a lot of impetus. We've built lots of new relationships, ones that we didn't have before. I would say there's some people around this table, we didn't have a kind of informal relationship that we've got now. And I think that that's thanks to the work that we've been forced to do actually over the last 12 months. So we're keen that we don't lose any of that progress. I think the ICP needs to be meaningful. And by that, I'll try to explain, and I'm happy for Philippa and Sue Rooston and others to come in. The ICP, the Integrated Care Partnership, needs to drive the local agenda. It needs to help shape the agenda. It's not an adjunct or an add-on. It needs to be central to it. And I think before, when we've tried to get this off the ground, the ICP in Hammersmith and Fulham, I think it's not achieved that really, and that's no one's fault. I just don't think it has. No one's got time. No one's got the time around this virtual table or any other to sit at a meeting that's not going to be useful and meaningful. So we're very keen that the priorities that are identified, none of which are set in stone, are actually incorporate everything we need to do in Hammersmith and Fulham. Dr. Nikki Langs also joined the board now. So she offers that empirical expertise on population health that we've also alluded to this evening. And hopefully Nikki can say a few words as well, because I think that's really good. And as I've said in many meetings, I think Nikki's really opened doors to building relationships with lots of colleagues here and elsewhere. And in terms of governance, I just wanted to say that I think that we're in quite a strong position in Hammersmith and Fulham, that we have made some progress in headway, that we can actually shape the agenda, the integrated care agenda, and influence the ICS, the integrated care system, rather than it being top down and shaping the ICP. We've got a real opportunity to shape the whole agenda. Philippa, I don't know if you want to add any more, but I'm conscious of time, so I don't want to waste too much time by means of introduction, because I want to leave a bit of time for questions, comments, and discussion. Thank you.
Thank you. Philippa, would you like to say anything? Or?
Yeah, if you don't mind, just 2 minutes, because I think just thank you, Lisa, for that. Nothing major to add, but just in terms of the emerging priorities, and what we have said is these are emerging and they're kind of the immediate priorities, and those have come out of the workshops we did with the primary care networks, which were really inclusive and involved and included local residents. So really important facts. So kind of taking all that information from those workshops and really trying to synthesize that into the key things that we think we can get going on and really are going to make a difference. So in terms of those priorities, diabetes, frailty, mental health and well-being, we wanted those to be really broad. So when we're talking about diabetes, we're not just talking about the medical management of diabetes, we're talking about diabetes prevention, we're talking about obesity, we're talking about food poverty, all the way through to the very specialist treatment. And we're just at the stage now where we want to shape those programs of work so that, as Lisa said, they're really meaningful across the borough, and that we're going to shift the dial on how we are performing across the borough, and also running through all those themes is the really important matter of inequalities. So using our evidence to understand where those inequalities are and then tackle them as a partnership by doing the things that are going to make a difference. So really resonates with what we've heard earlier this evening. Thank you.
I'm absolutely delighted to hear that, Philip. It's very inspiring, it's very cheering, and I'm delighted about the inequalities. And I make a plea that there is a separate piece of work almost, because I think it's that big at the moment. There's almost in each of your strands, staying well and living with illness and mental health and recovery, and that there's a separate piece of work where you actually identify that you're doing some real I think the word of these days is granular. Everyone's saying granular. Yes. That you do some real drilling down and working with like an ethnic minority people, also recognizing people from different ethnic backgrounds will think different. No one's going to think in a single way, but actually doing some real granular work rather than just a slight, you know, it's alongside, but it needs to be, I think,
yes,
brought out, and I'm
Chair,
appreciating mentioning it.
Yeah, Chair, I should have said we've approached that in exactly that way. So the health and wellbeing work stream will be the major work stream on the inequalities, but now each of the other work streams, there is obviously inequalities threaded throughout. So we've that kind of matrix way of working in mind. We just need to scope it.
Excellent. And did Nikki, did you want to add something there? I heard you mentioned.
I was just going to say, I was just going to say briefly, Chair, I'm happy to have been invited to join the Integrated Care Partnership. And I think what we can add in public health is also looking at wider determinants of health. So the environment that people live in, their access to jobs, education, and also housing, which is really important. So really good, as Philippa said, to kind of weave in all the upstream factors and downstream, and also a lot of community engagement and listening to people.
Brilliant.
Thank you.
Thank you. I'm going to bring in a couple of questions I've got. I see Jim first, and then some Meryl.
I think it's been really heartening to listen to this presentation, simply because it follows on virtually organically to what had gone before. I think what Chris Whitty said was quite interesting, and it struck me, it's slightly chilling, because we've had a dreadful year and it goes on. What we've been involved in the borough really is a remarkable set of kind of firefighting. We've had to use all the energy we possibly can to vaccinate people, to protect people. But what actually strikes me there is that relationships have been built up, but relationships can't be sustained unless they're institutionalized in certain kind of ways. People simply run out of energy. And as we move into a new world with the ICS, the ICP, I think, because it talks to so many people at local level, must be what leads the ICS as far as local decision making is concerned, because decision making is what it's about. Local people, I think, will continue to support, to work with those who actually make decisions. I think local residents, if they find that decisions about their health, about provision and so forth, are made at a great distance, will be much less likely to keep on in the way people have done so admirably over a year. So it's institutionalizing place within the ICS and assisting on place-making decisions, which will include pressure on budgets, for example, on health policies, looking at PCNs, for example, looking at ways within all of those of having public involved early on in decision making, which then goes upwards, rather than reacting to decisions which comes downwards, because new organizations like the ICS, quite understandably, tend to grab power first, but the work which has been working so well has started at the level of people on screen, and we need to insist on that, our decisional powers.
Couldn't agree more, Jim. I can jump in there. Couldn't agree more.
Thanks.
And it's unusual, because I think for the NHS, I mean, I'm really, really excited and happy to see, you know, Philippa, and not just because of your family, we look delighted to come and join us more. Health and Wellbeing Board is here for families. But I'm just delighted to see the NHS is also grasping this well. I don't think anybody wants to lose this, and it can be challenging because we come from different directions. The NHS comes from this behemoth bureaucracy that, you know, you're all having to fight against all the time, and we come from this sort of a different place, which is also, but it has its own bureaucracy attached to it. But if we can keep this going, you know, the ICS is a new baby in town. It's not set in stone. We're all working out how we can make this work. The really important thing is that in this borough, we will carry on making sure, and what you're going to be doing is when you talk about your fifth priority, develop the ICP with PCNs at the heart of local communities. I think also how you make sure, and you talked about the workshops that you've done, how you make sure that residents are constantly able to ask questions, scrutinize, be involved and shape it. And I think you've made a great start. which segues neatly into Meryl, I guess, and then Toby.
Thanks. Perhaps I want to develop partly what Jim said, but I agree completely with what Lisa said introducing this. The ICP could, and in my view should, be hugely important for health developments in the borough. And as Philippa said, inequalities ought to be core concern there. But I think perhaps, well, I'd like to hear more, perhaps not now, but later, about how indeed this bottom up is really going to happen, and how co-production is actually going to be, because I know the borough has a commitment to co-production, how co-production is going to be brought into the work of an ICP. I asked that because I was one of the people, as was Jim, who was involved in one of the 3 PPG meetings with the ICP. Feels like years ago, but I guess it wasn't. But anyone who's on this board who was at the meeting at the South Fulham meeting will remember that towards a later stage of the meeting, the issue was raised. Actually, Jim and I are not sure whether he raised it first or I did, but both of us emphasized it. Where was the patient? There was a lot of very interesting discussion in that meeting, but for the patients who were actually in that meeting, despite the fact that it was meant to be a PPG meeting, the patient voice was missing. And I think that's going to be a crucial voice to be actually heard as the ICP develops, if it is genuinely going to meet the needs of patients in the borough. So in practical terms, we do need to start working from the bottom up. We need structurally to look at how the voice of patients can be included from the start. Yeah. And I'm tempted to ask, in terms of the priorities, have patients had a say in determining what those priorities should be? They may have. I don't know. I know I haven't been asked, and I know some of those priorities I would fully support. But it is the patient voice being heard right from the start as the ICP develops?
Well, Meryl, I'm going to not ask people to respond to that. I'm going to take that as a very powerful and important point to be reflected on. I would also beg us not to talk about the patient. I don't feel I'm a patient. I feel when I talk to NHS in the technical world of the National Health Service, we're all patients, and GPs have patients on their books. But talk about people and residents. If you say, what do you want as a patient? People don't know. But yeah, we'll come back to that. It's a really strongly made argument, point, which is fundamental to what the council's about. Toby, you've been very patient. Get it?
Very good. Just 3 quick points. One obvious one really, which is, this is not our first go at this, either in Hammersmith and Fulham or elsewhere in North West London. I think at one point I was on 4 different ICP boards, which sadly, I think there was a genuine challenge about converting all of the brilliant expertise and enthusiasm of people in the room to genuine practical benefits for the residents that they were trying to achieve. And these things are not easy. So I guess it's just a kind of note that we need to learn from all of that. I guess the other side to that is we don't really have a plan B, so we need to make it work. So, and there has never been a better opportunity, I think, to properly build on all of the learning from the last 12 months and make these partnerships effective. So we should go for it. 2 other quick things. One, I've got kind of increasing gang of clinicians from Imperial who are desperate to get involved in working alongside GP and community partners to improve outcomes for local residents and our population. and that's brilliant to see. And I'm literally holding the reins on them at the moment. So there's a kind of a sense that we need to work out how best to do that in a way that fits with all of these plans and helps to drive some of the ambitions of these ICPs. And my final point really was, I think the paper was great. With my kind of transformation hat on, there's something about measures and how we might go even further to start to look at how will we know in 12 months' time that what we've done has translated into benefits for local residents. And I think if we could kind of do a bit more work on that, perhaps, that gives us essentially a bit of a mark scheme that collectively we can hold ourselves to account for, to say, is this, delivering benefit? Is it a good use of taxpayers' money?
That's very, very helpful. I'm going to bring a couple more people and then ask Lisa and Philippa to sum this up, if to come back on some of the points that have been raised as well. I've got Jackie and then finally Sue.
Hello, hi. Thank you very much. A really good paper and a brilliant discussion. Just a reminder that children and young people are our young residents and need to be featured in this. And I know that that's quite difficult, it's complex, but I'd like to see them really front and center as the future citizens, the young citizens of today and tomorrow's adults. They'll all be in these roles that we currently occupy, and just a plea to see that more explicitly, please.
Yeah, I think there's a big here going around quite silently in the room.
Thank you.
Sue.
It was just to pick up on what Toby had said in terms of sort of engaging clinicians. And I think, we're at the opportunity where we're sort of scoping sort of our work, and it talks to both of your points. Who can we include in terms of clinical input and how we do that? But also as part of the scoping of those priority areas, what are we going to be measuring and what are going to be our outputs from it? So we've certainly sort of already started to think about some of those, and definitely we will iterate it. And I've also been in touch with Anna as part of the sort of the work to see who else we can link in with our both board and our exec group in terms of sort of the imperial linkages.
Anna, just for those who don't know her. Who do you mean by Anna, just for those who don't know her?
Sorry, it's Anna Bakobsa. I can never say her name. Anna B, I call her, but she works at Imperial. Yeah.
All right, thanks. Philippa, do you want to come back and then Lisa on any of that?
Happy to start. Do you want to start, or I'm happy to start, Philippa, and then you come in. So all great points, and people will be members will be very happy to know that they're all things that we've been grappling with and taking into consideration. There's not anything that's been said that we haven't been looking at. So in no particular order, I think, Toby, you talked about the challenge of making it meaningful, and I think that's definitely something. I said in my introduction that it needs to be cool. Otherwise, what's the point? We've got a lot of people sitting around, and we need to make it meaningful, and we're determined to do that. The point about measures and outcomes, absolutely. We need to know that we've made a difference, and that it does have benefits. Otherwise, again, what's the point? And we always need to be, I think in anything we do, any of public sector work, we need to be doing that anyway. So quite clear about that. Jackie, on your children and young people need to be front and centre. And just to give you a bit of the behind the scenes, so we had a longer list of priorities, but we've had to kind of distill things down, and in our engagement so far with stakeholders, try to not have so many priorities and try and have broad priorities so that we can sort of pull them in. But absolutely, we did have an explicit one about children and families, and I think I can send you what's the detail of what's written. But yes, very much front and centre, and very much debated. How many, and of course there's lots of different views about it. On the patient voice, Meryl, you made very strong argument, and again, that's I think that's something definitely we've got to do. We've got to start doing. I need to be honest that I don't think we've done that enough to date. During the sort of initial setting up of it. So you're absolutely spot on, and that's something that we need to do. I think we're engaging an awful lot of, we've been trying to engage an awful lot of stakeholders and try to distill down the priorities, but you're quite right that we do need to bring in, and we're probably more ready to bring in the patient voice in, resident voice in now. So Philippa or Sue or anyone, I'm happy for you to, if I've not covered those points very well, or if I've missed things out, more than happy for you to come in.
Just to add, Sue, Lisa, that we've got a tiny bit of resource that will help us do that better engagement that you referenced as well. So in our tiny program team, which is a program manager and half another person, we've got some resource in there now, as well as an analyst as well. So I think that will help us going forward.
Yeah. Well, thank you. I mean, just the point that Toby raised, which I thought was an interesting one. He's got this great group of consultants. What's the collective noun for a group of consultants? A determination of consultants.
I daren't make one up.
A Roberts and Justice of consultants. They are, the thing is, if they don't get engagement through the ICP, being the active guys they are, they'll go to the GP Federation, or they're just contacting PCNs individually. And it's better if we can bring everything together so that everyone is pulling through the same. We don't have too many things going on, because it gets bureaucratic in a different way. Obviously, people shouldn't be inhibited from going out and making their own links. But it's great, Philippa, that you have some resource for the consultation. I think as a council, if you need to call on us in enabling that, we obviously do newsletters to thousands of residents each week. We do lots on Nextdoor. We reach out. We'd be very happy. I mean, I think this is part of why we're so happy that you and Lisa are co-chairing this, that the council and CCG are co-chairing this, that we really make this co-production, this engagement with residents quite different from anything that's happened before, but the outcomes therefore a lot better and a lot happier, a lot as a result. Yeah. Look, thank you so much. Lisa, come in. Yeah, sorry.
Yeah, no, I just forgot on the co-production, because we've been so busy with it all. We've already talked a while ago about getting Tara and Kevin, our strategic co-production leads in the council, involved. So we've got a ready-made group, haven't we?
You've got a ready-made group for disabled people, absolutely.
Yeah.
And we've talked about the need to work with Black and ethnic minority in a different way as well. And there will need to be groups set up there, which we can have Health Watch and others help with. But I think this reaching out to the community in a way which hasn't happened before, recognizing the desire to be involved now. That's what the new world is about. And the fact that we can reach out so easily, ironically, through Zoom and Teams is also, although we will start being able to, thank goodness, to meeting again soon. But that's the change. Health services, care services shaped by everyone that they're there for. So we're not really here for anyone else. But for us, we're only here for everyone else, whether we call them patients or residents or people. Thank you very much. You've been very kind. We've run over a little bit. I'm sorry about that. We've covered a lot of ground, and I think we've got some things to reflect about and take forward. It's been helpful, and we've had to lose Dr. Bob, but those of you who find it interesting, who aren't already signed up to the huddles on Tuesdays at 6 o'clock, they're well worth coming along to, and I think they're going to be also an important part of what we do and everything else we've talked about. They're the outcome of that. Great. Is there any? I'm afraid I'm going to be a little bit cheeky and say we're not going to run through what's coming up at future meetings, because we discussed that quite a lot at other meetings. So unless there's anything urgent on the forward plan that somebody would like to raise, which we haven't raised, no, I'm going to bring this to a close then. And thank you all very much. Hope you all have a good evening. Enjoy your dinner. Maisie, thank you very much. And
thank you, Ben.
Okay. Bye.